Chitra, can you show my screen?
Yes, ma'am. Yes, ma'am.
Yeah.
So, good evening, everyone. It's a pleasure to introduce Dr. Divya Narasimhan, ma'am. She is a consultant gynecologist at Belroth Hospital, Chennai. She is a recipient of Johnson Medalist from Madras Medical College. Her field of interest is laparoscopy. Now, I hand over this session to Dr. Divya, ma'am, for the further proceedings.
Good evening. We welcome you all from TNIAGE for this informative webinar. We have excellent eminent speakers here, and we are going to be chaired by Dr. Rekha ma'am with all the knowledge in the field for quite a long time. We have taken a very confusing topic, like when we go in with laparoscopy and we see certain masses in the adnexa, we are always perplexed whether to go ahead with laparoscopy or whether to go ahead with a laparotomy, or even whichever way we decide to do, how to do it properly so that the first surgery is the best surgery for the patient. With that, we welcome our chairperson, Dr. Rekha ma'am, to give the inaugural address.
I think you'll have to unmute, ma'am.
Ma'am, please unmute yourself.
Oh, okay, sorry.
Yeah.
So it's great to see the session in progress, and the invited speakers are all here, so it is great. And I must congratulate Divya on putting the program together and having invited many of the speakers here for this session. Now, this session will look at adnexal masses and how to best deal with these situations. So who's the first speaker, Divya?
Dr. Anusha ma'am.
So
Yeah.
Dr. Anusha, I think she's here. So yeah, please give her introduction. And I must congratulate all the people who have got selected to the IAG board, Damu, etc.
Thank you, ma'am.
And Meenakshi, I don't think is here now. Yeah,
Sure.
let's progress. Divya, you can go ahead
Yes.
with the introduction for Dr. Anusha. Yeah.
I call upon Dr. Anusha to start the first session with the ORADs, giving clarity.
Thank you, Divya. Good evening to everyone. Without taking much time or much delay, we'll just move on to the topic. Now, we have a 46-year-old woman presenting with vague abdominal discomfort, and an ultrasound shows a 7-centimeter multilocular cyst with one small solid projection.
Have to share your screen, Dr. Divya.
Yeah.
Doctor.
We will just share the screen.
Yeah. I think you have to just go to full screen. Yes.
Is it visible now?
Yeah. Please go ahead.
Okay. Now we have a 46-year-old woman who presents with vague abdominal discomfort, and on an ultrasound it shows a 7-centimeter multilocular cyst with one solid projection, and her CA-125 is mildly elevated. Now the report says complex cyst for suggested clinical correlation. Now she's gone to 3 people. One of them has reassured her, one has said she needs to get operated ASAP, and one has referred her to an oncologist. She has also consulted the Google doctor who has given her the surgical procedure as well. Totally. But then what is she going to do now? And here we see same patient, 3 different specialists have seen and 3 different pathways. So why is this inconsistency happening? Is it because of the reporting? Is it because of the ultrasound lack of proper imaging that we have? No. That's because we have a FOMO of missing out malignancy. So the ultimate goal here is to optimize ovarian cancer outcome, and also while considering minimizing unnecessary surgical procedure in patients at low risk of malignancy, also reduce the surgical morbidity and maintaining hormonal competency in these patients. So in order to do that, what we need to do is we need a standardization. Now, what is this ORADS? There comes the ORADS. ORADS is ovarian adnexal reporting and data system. US is ultrasound. Now, today basically we're going to talk about the ultrasound system. Now, this system is a simple measure. This is a risk stratification and a management pathway, which is a simple measure in order to reduce this inconsistency. It aids consistent interpretation, and it also reduces the ambiguity when we are dealing with malignant masses. Now, how does it take off the ambiguity is it has a controlled vocabulary, which they call as a lexicon. Now, these lexicon, they require certain descriptions, which are actually given by the guidelines. This description can be used by anybody. So again, it also defeats the fact that you need an expert sonologist here. So you use the descriptive terms, you use the lexicons properly, anybody can report, and that actually eases everyone. Now, and also it does not diagnose cancer, it only estimates the risk. So what are all the governing guidelines? Where do we apply this? Now, this is applied to an average risk patient who is a patient who is not symptomatic, that is no acute symptoms, and also no substantial risk factors like a family history of ovarian cancer or a patient who carries the BRCA1 gene. Now, they are high risk patients. They don't come here. It can be used in both premenopausal and postmenopausal women. And the lesions should be pelvic in origin and should arise from the ovaries or fallopian tube. And there are other lesions which also can come into ORADS, which are the paraovarian cyst and the peritoneal inclusion cyst. The broad mesenteric cyst does not come here. And who all you need an ultrasound specialist. That can be a sonologist or a radiologist or anybody who's trained in ultrasound who are well versed with the descriptive terms. And transvaginal ultrasonography is used here. See, you can use a transabdominal or a transrectal, but they are value added ad hocs. Now, the size of the lesion is something that is very important here. Regardless of whichever plane it is, the largest diameter is taken into account. And in case of multiple or bilateral lesions, each lesion is measured separately, and the lesion which has the highest ORAD score is taken into management. Now that's taken into the management pathway. Now, these are the small factors, these are the descriptive terms. Now, you use the maximum diameter of the cyst, you use the maximum diameter of the solid tissue, and the number of locules, number of papillary projections, acoustic shadows, and add-on findings like ascites or fluid in the cul-de-sac. Now, again, this is how the ORADS defines each cyst. Now, the basic important major categories are, the first thing is to identify whether it is a physiological cyst or it is a non-physiological lesion category. Once you identify the lesion category, you go and find out the size. And then once you find out the size, go inside the cyst, look at the solid areas, whether they are regular or irregular, and then see the internal contents. When it is a solid area, when there is a solid area, the most important internal content that we see is acoustic shadowing, which will actually categorize it into a benign lesion. And then you have cystic lesions, which can have both solid components and which can have internal contents. Solid components are papillary projections. Internal contents are either anechoic fluid or hyperechoic fluid. And then you have certain benign descriptors, which we'll discuss during ORADS 2. Then the color coding, which is very, very important, which is only going to classify the malignant lesions. You have 1 to 4. And then apart from that, you have few addendums for extraovarian lesions, which are fluid descriptors in the cul-de-sac, and in the abdominal cavity. And then you have peritoneal thickenings and nodules. So moving straight to ORADS. Now, what is ORADS 0? ORADS 0 is incomplete evaluation. You're not able to totally tell what the cyst is, either due to bowel gas or the cyst is too big to come into the picture, or the location of the adnexa is very difficult, or the patient is not cooperative and not able to tolerate endovaginal imaging. Now, here you directly go to other modes like ORADS MRI. Now, next is ORADS 1, which is basically a normal ovary, which can be a follicle or it can be a corpus luteal cyst. Here we follow the simple 1, 2, 3 rule of the ovary, either a follicle, dominant follicle, or a corpus luteal cyst. Now, this is zero likelihood of malignancy. Next, we have ORADS 2. ORADS 2 has a less than 1% likelihood of malignancy, and this is where the confusion occurs. Now, these cysts are typically between 3 to 10 centimeters, and this only causes the confusion of whether we have to refer the patient anywhere to a gynec-oncologist, basically. Here, there are specific features here which we need to look into it and then categorize them. A typical hemorrhagic cyst, like we all know, has a reticular and a lacy pattern. Typical dermoid has floating echoes, which is easy to identify. And then an endometrioma, the typical ground glass and homogeneous appearance. A paraovarian cyst is separately seen from the ovary. Peritoneal inclusion cyst actually moves along with the peritoneum and the pelvic organs. That is easy to identify with the bed. And then a hydrosalpinx has a typical tubular and incomplete septations. All these are categorized into ORADS 2, and this is where unnecessary surgery or necessary surgery, the decision happens. Now, ORADS 3 is where there is 1 to 10% likelihood of malignancy. Here we choose a number 10 because both Adnex model and all the Girard's model, everything says that the size 10 centimeter actually has the highest risk of malignancy. So 10 is the magical number here. So any cyst more than 10 centimeters, depending upon whether it is unilocular, multilocular, solid components, depending upon that, and color flow from 0 to moderate flow, they are categorized into ORADS 3. ORADS 4 is again the same thing, multilocular, unilocular, solid or liquid, solid areas or not, along with an extended vascularity up to type 3 vascularity or type 4 vascularity comes here. Then type 5, again the same findings with higher vascularity and addendums like ascites, peritoneal nodules and fluid in the cul-de-sac are added here. Now that we've on the whole, we have certain points. We have solid areas, we have papillary projections, we have irregular walls, we have strong vascularity, we have ascites and peritoneal nodules. All these are given in simple M rules and B rules in IOTA classification. Then why do we have to go for this ORADS? That is for a simple rule that when we go for the simple rule risk calculator or an LRS model or Adnex model, now this is basically a mathematical calculation which includes tumor marker, which includes the age, which includes other factors, external factors also. But then when it goes to ORADS, it is a pattern recognition which will actually help us in making a pre-operative diagnosis so as to go into a proper management pathway. So that is where the ORADS scores against this. Now, this is the ORADS, how we incorporate IOTA model into the lexicon descriptors of ORADS, and how do we calculate the scoring in ORADS and what affects the management. Now, here, step 1, you identify whether it is a normal ovary or they are classic benign lesions. When they are classic benign lesions, normal ovary, you don't do anything, it is ORADS 1. When classic benign lesions, you incorporate this Adnex model here and you get the risk calculations, and then again categorize them into the ORADS model 2, 3, 4 and 5. Now after categorization, what you do, you have in ORADS 0, it is an incomplete evaluation. You either have to do an MRI or you just leave it be when there is nothing. In a normal ovary, you don't do anything. In ORADS 2, in almost certainly benign lesion, depending upon the symptoms of the patient, size of the lesion, we take a clinical call whether to operate or not. ORADS 3, again, there is no need for a consultation of a gynec-oncologist. This can be managed by a gynecologist. 4 and 5 will be an escalated one to a gynec-oncologist. Now, this is a joint statement that was issued in 2021 by ESGO, ESGE, and ISsueOg, which actually says the same thing. They concur with the findings of the ORADS model and their management pathway. So what happens? Let us just do a little comparison. What happens when we don't standardize? We have this S rules and the M rules. We don't standardize and we just go on with the simple S rules and M rules. We get plenty of complex cyst or suspicious cyst clinical correlation reports. And it's a subjective interpretation. See, some people can say solid areas to papillary projection, small, big, everything. There are no controlled vocabulary there. So you need an expert sonologist there to come in and give another opinion. And there are variable referrals. You either operate, you don't operate, you refer, you don't refer. The deserving cases don't take their proper pathway. But when with ORADS, you properly structure, you properly standardize and stratify the risk, you have a clear risk category, you have clear pathways to refer and to treat. And why you have again IOTA. IOTA also has pattern recognition. But then how ORADS is better than that? There is no risk stratification in IOTA. You need a expert sonologist there. And the clinical implication is very indirect because you need other factors like CA125, you need the premenopausal, postmenopausal status of the patient to include here. But ORADS is not like that. It is a direct clinical approach when you use the ORADS. Now comparing RMI and ORADS. Yes, again RMI also uses detailed morphology, but then here it is a numeric index. It only says you refer to somebody or you don't refer. You either follow up, you operate, or you refer to a gynec-oncologist. There are gray areas, the 3 to 10 centimeter tumors, the actual benign descriptors are missing in the RMI. Though it is even then, because of validation, it's still in use. But then integration of iota into ORADs makes it a even more stronger validation for general gynecology use. And then what ORADS does actually, it operating on unnecessary hemorrhagic cysts are avoided. The panic over classical dermoids are avoided, and overcalling endometriomas, especially endometriomas in perimenopausal age group, and referring every multilocular cyst to the oncologist. All this can be avoided with ORADS. And where actually Adnex is superior, we cannot, ORADS doesn't replace the entire staging. Adnex is superior when it comes to malignant tumors which need to be managed, because Adnex does not treat conservative adnexal tumors. Adnex actually distinguishes between borderline and invasive cancer, which is very, very important and the need of the hour now. But it predicts the probability, but it does not give a standardization. ORADS gives a standardization of practice for general gynecologists. And then a short comparison between when to use ORADS ultrasound and when to use ORADS MRI. See, ORADS ultrasound is a triaging tool and a first line tool, whereas MRI is a second line and a problem solving tool. And it's entirely operator dependent, ORADS US, whereas MRI is protocol driven. It is highly sensitive, it is highly specific, and the specificity of ultrasound can be increased by adding CA125 there, but that is still underway to study, and it does not replace, it cannot justify the term pattern recognition only when we add a CA125, but the sensitivity, specificity can be increased. And the categories are 0 to 5 in ultrasound and 1 to 5 in MRI. The diagnostic use is initial OPD evaluation when it's ORADS US. When it's MRI, it is used majorly for indeterminate lesions like 4 to 5. 4 to 5 can be used here. The logistics wise, yes, it is widely used and cost effective. This is higher cost, but actually reduces unnecessary surgeries. Now, to end my talk, ORADS is a risk stratification tool and it is not a diagnostic modality. Categories 2 and 3 can be comfortably managed in general practice. 4 and 5 definitely require oncology input. It reduces unnecessary surgery, it reduces the tension of missing out a malignancy, and it strengthens clinical judgment rather than replacing it. So it is not just a scoring system. I would conclude by telling it is a safety framework for both the doctor and the patients. Thank you.
Oh, sorry. I think I was muted. Can you hear me now?
Yes, ma'am.
Ma'am, can we take the questions at the end of all the three speakers, ma'am? That would be better. I think Rekha ma'am is...
Lost her, I think.
Okay, we'll take all the questions at the end of all the three speakers. So I think now Anusha has given us an idea. The Master Chef, when they have it on the show, they'll call it as a crepe with clarified butter, with lentil soup and all those things. They can afford to talk it out differently, and the layperson can talk it out differently. But when it comes to us, when we are seeing these ovariances, we need to have a uniform norma, so that when we talk to the patients nowadays, they also come with all these, with the chat GPT, the ORADS 1, 2, 3 and all. So we should know a little bit, and I think we've at least become sensitized to this, and we
Rekha ma'am is back. Ma'am,
Rekha ma'am is back.
Oh, you couldn't hear me?
no,
Yes,
ma'am. We
ma'am.
lost you for a bit.
We lost you.
Oh, okay. No problem. Go on.
Yes,
You can
ma'am.
just go on. Yeah, no issue.
Yeah.
Go on with the
We'll
next.
we'll
Yeah.
go to our next speaker, Dr. Prasanna, who's a consultant at Mala Fertility and Research Center, Tambaram. Over to you, Prasanna.
Good evening, everyone. First at the outset, I thank TNIHG and the IIHG team for giving me this opportunity. Today's my topic is adnexal mass in postmenopausal women. We know the adnexal mass is the mass arising from the ovary, tubes, and the surrounding structures. Even though in postmenopausal age, the frequency of benign will be more compared to the malignant lesion, but age advances, the risk of malignancy also high. So we always need a proper preoperative assessment to know the risk of malignancy. So we need to do the appropriate workup for the optimal outcome. The incidence of ovarian cyst in postmenopausal women is 5 to 17 percentage, out of which 60 to 70 percentage was benign. So what are the differential diagnosis for ovarian cyst? Adnexal mass, it can be functional, ovarian endometrioma, tubo-ovarian mass, mature teratoma, hydrosalpinx or paratubal cyst, serous cystadenoma, and peritoneal inclusions, cyst and persistent pedunculated subserous leiomyoma, malignant ovarian mass. The above are very rarely seen as functional endometrioma and tubo mass in postmenopausal.
Sorry to interrupt. Jnanashankar sir, if you're here, also please join ma'am to chair this session, to chair this talk. Thank you. Thank you.
Okay.
I think I saw him. That's why. Yeah, he's here. He's here. Thank you, sir.
Can we continue, sir?
Yeah, let's continue.
Evaluation of adnexal mass, we always begin with history, examination, imaging, and serum markers to assign whether it is a probably benign or malignant lesion. Why it is important to identify a high-risk adnexal mass? We have to give them whether it is a conservative expectant approach or the immediate surgical intervention, whether it is a laparoscopy or laparotomy. If at all a laparoscopy, whom should we do? Whether by the gynecologist or gyneco-oncologist? If at all we decided for laparotomy, which site of which type of incision, whether it is a midline or vertical incision, whether we need the intraoperative frozen biopsy or paraffin biopsy. If at all, if it is a conservative surgery, whether it could be ovarian cystectomy or bilateral salpingoophorectomy, or it is a complete staging procedure. Coming to the history, we know as the age increases in nulliparity, early menarche, late menopause, and history of endometrioma all increases the risk of malignancy. And those with the family history of ovarian, bowel, breast cancer, and some hereditary syndromes like the BRCA1 and 2 mutation carrier, HNPCC, and those postmenopausal women with the symptoms suggestive of irritable bowel syndrome like symptom in the last 12 months, above 50 years also increased risk of malignancy. She can present with various symptoms like a non-typical back pain, sometimes bloating, constipation, abdominal pain, or urinary symptoms. Sometimes they can present with acute abdominal pain also. Torsion, hemorrhage also happen. So we have to do the proper clinical examination to detect the palpable related solid mass or cystic mass, and also the ascites and pervaginal examination. What is the imaging modality? Transvaginal ultrasound is the first imaging modality. When the size is bigger, we can supplement with the transabdominal ultrasound also. Usually CT, MRI, PET is not recommended for diagnosing adnexal mass. It is for staging when you have the suspicious mass or malignant lesions. What are the tumor markers? CA125, cancer antigen 125 we can use. It is for the complex lesion to aid the diagnosis. It is not a definitive diagnostic tool because it is elevated in other inflammatory conditions also. There are other risk assessment tools, but not used much. We usually use RMA, IOTA, and ORAS. So, malignancy index, how to calculate? It is a product of menopausal state, ultrasound score, and CA125 level. The score 1 for pre-menopause and score 3 for postmenopausal. And RMA cutoff we used is 200. Those more than 200 will increase the risk of malignancy. Those who have the less than 200, the risk of malignancy will be less. So the RMA based the RCOG classification. If the cyst is less than RMA is less than 200, if this asymptomatic cyst less than 3 centimeter doesn't require any follow. If the cyst is 3 to 5 centimeter unilocular and unilateral cyst, we can offer them a conservative management. So this patient can be followed up once in 4 to 6 months. In the follow period, if the cyst is resolving, we can discharge from the follow. If there is a persistence in cyst, we can again follow up the patient around 4 to 6 months. So individualize the patient treatment according to their wishes. If there is change in future, we can intervene. When the RMA is more than 200, the risk of malignancy is high. Thus, we have to subject them for the CT and multidisciplinary team review with surgical oncologist. Based on the risk again assigned higher likelihood of malignancy, we have to send it for gynecologist. If it is less risk, we can operate by trying the gynecologist with the laparotomy and staging procedure. There is then IOTA model came. This in the 2000 it was published. Based on this IOTA, they already this is discussed by the previous speaker. I'm not going too much. After IOTA, there is less patients subjected for surgical intervention. And ACR 2018, this American College of Radiology also given many scores for the predicting the risk of malignancy in the postmenopausal ovarian mass. So combining the ORAS and the IOTA Adnexa model, the risk is estimated. So from the joint statement, if it is ORAS score 2, it means the risk of malignancy will be less than 1%. If patient is asymptomatic, we can manage expectantly. They can be followed in 3 months, 6 months, 12 months with ultrasound. If she is asymptomatic, we can go ahead with the surgery. And the ORAX 3, that means the low risk of malignancy, it is 1 to 10%. It can be managed by the general gynecologist. If it is ORAX 4, that is based on the Adnexa risk, the risk will be 10 to 50%. So we can subject them to the gyneco-oncologist center. If the ORAX 5, that means more than 50% of risk, we can refer to the gyneco-oncology. What they will do in gyneco-oncology, they will do the advanced imaging with the other tumor markers. According to them, they will manage. Then we can give the conservative management, the postmenopausal ovarian cyst. If it is asymptomatic, simple unilocular ovarian cyst, the risk of malignancy will be less, so do not require follow. If it is 3 to 5 centimeter cyst, the risk of malignancy also low, so we can follow them once in 4 to 6 months. Surgery. So surgery depends upon the skill of the surgeon and experience of the surgeon. So we have to give them the proper preoperative counseling with the pros and cons of each method, and we have to also counsel them for the laparotomy, conversion to laparotomy also. And again, the setup of the surgery, whom they operate also very important, whether it is a general gynecology unit or gynecologist unit. So, what is the role of aspiration of ovarian cyst in postmenopausal women? Usually, it is not recommended, only for the symptom control in advanced malignancy. And aspiration of ovarian cyst also associate less effective. It also associated with a high rate of recurrence. Sometimes using cytological examination of the ovarian cyst fluid also poor in predicting the benign and malignant lesions. Its sensitivity only 25%. So even if you aspirate the ovarian cyst, it induces the spillage and seedling of cancer cells into the peritoneal cavity. It upstage the disease. Please don't do the aspiration of ovarian cyst in postmenopausal women. Can we manage postmenopausal women by laparoscopy? Yes. If the RMI score is less than 200, we can operate. Or ORAS 2 and 3 also, we can go ahead with the laparoscopy. And it's comprised mainly of bilateral salpingo-oophorectomy rather than the cystectomy. And also we have to do counsel them preoperatively. Sometimes staging laparotomy is needed if any suspicious malignancy. And specimen should be removed in back to avoid spillage, because a spillage of the specimen will lead to increase the chance of recurrence if at all malignancy is suspected. So you can retrieve the specimen back whether umbilical port or transvaginally also. During laparoscopy entry, care not to rupture the mass. If it's a bigger mass, you can use the left upper quadrant port also. Better, even if it is difficult case, it is a midline scar above umbilicus previous scar, we can use the open entry also to avoid the rupturing of the mass. Why spillage is avoided? Because even the pre-op intraoperative assessment does not preclude the malignancy. So it can lead to the increased recurrence and upstaging of the disease, and also it affects badly the patient's prognosis. So the chance of recurrence is high within a 1 year. So this is the small video which show that this is a case of 44 years. She's a surgical menopause, 39 years. She underwent TAH with the RSO. She is a case of classic benign dermoid cyst. It was 8 cross 7 centimeter. We did in-back cystectomy. During the cystectomy, there was a rupture happened, but there is minimal spilling within the back. It is another one small dermoid also there. We did a cystectomy. Patient doesn't want for oophorectomy, so we just do the cystectomy and left the salpingectomy, and we retrieved the specimen via the umbilical port and specimen retrieved. Why the umbilical port is chosen? Because it will be less painful and faster retrieval time. If we use the lateral port, there is the risk of inferior epigastric vessel injuries, and if at all if we use the lateral port, we can use the port closure needle to avoid the future incisional hernia. This is another video. This is I got it by my friend, and she's a case of yearly postmenopause, just 13 years, 13 months amenorrhea. She's a postmenopausal bleeding with a large ovarian cyst, left-sided ovarian cyst. Based on the warrants, it was category 2, but bigger size. We did left salpingo-oophorectomy, and after the TLH procedure, the specimen put it in the Euro bag, then the specimen retrieved vaginally. This is another small video. She's a case of postmenopausal woman with acute pelvic pain. She had a small ovarian cyst around 2 centimeter, but she had severe pain, not tolerating to any medications. There was minimal free fluid in the ultrasound, so we put a scope. We just see there is a lot of peritoneal deposit. We taken the biopsy from this deposits. We not done anything. We just given the wash, and there is small free fluid in the pelvis, also not much ascites. We send it for the cytology and the histopathology. It came out to be adenocarcinomatous deposit, that is a primary from the lung. So whenever we encounter the postmenopausal woman, so we have to reconfirm with the expert radiologist before taking case. And when should we perform laparotomy? All ovarian cysts suspicious of malignancy are RMI more than 200, and imaging suspected malignancies, or during laparoscopy suspicious malignancy. If any subsequent histology showed malignant lesions, we have to go ahead with laparotomy. So whom should do the laparotomy? Just by the trained gynecologist or the gynecologist. We have to clearly document them and proceeded with the total abdominal hysterectomy with bilateral salpingophorectomy with omentectomy, and bilateral pelvic and paraortic lymphadenectomy. And we can take in the cytological, ascitic fluid or peritoneal washing for the cytological assessment, and also biopsy from the suspicious area. And we have to do the proper surgical staging. To summarize, to always do the proper preoperative assessment to assign the risk of malignancy. Aspiration of ovarian cyst is not recommended. Whenever conservative surgery we follow, we can go ahead with bilateral salpingo-oophorectomy rather than cystectomy in postmenopausal women after proper counseling. And spillage of cyst content should be avoided where possible, as preoperative and intraoperative assessment cannot absolutely preclude the malignancy. Whenever possible, please use tissue bags to avoid spillage and spread of malignancy. Thank you. Thank you again, IH team, for the opportunity.
Rekha ma'am?
Yeah.
Jnanashankar sir?
Unmute.
Sir, you need to unmute your...
Perfect. I think she covered all aspects and made it very practical and relevant. I'm not sure whether there are any questions that have been asked.
No, not
No,
yet,
sir.
not yet.
We'll have the discussion. Yeah. Chitra, can you put up Dr. Sejal's CV? We welcome Dr. Sejal Naik, who is the treasurer of IAGE 2025,
Yeah, welcome, Sejal.
chairperson of the endoscopy. Ma'am, Rekha ma'am.
No, I'm just saying welcome to Sejal. We are so happy to have you here.
Thank you, ma'am. Thank you.
Yeah.
It's always pleasure to be here with Tamil Nadu. I'm sorry, I am having little my bad throat.
Yes, ma'am.
Shall I?
Yeah, we'll start with your presentation.
Yeah. One second.
Before she starts, I think I also want to mention about how much the Eagle project has taken off, because after it has come under her leadership, I think we've done more than how many, ma'am? 150 we've touched?
Yeah, we have done 127 last year.
127. So that's a great achievement, and kudos to you. Looking forward for many more projects. Thank you. On to you.
Thank you, Damodar, for being one of the core member for the Eagle.
Yeah,
And it
thank
is really amazing. The concept is really a beautiful concept to start the endoscopy at a very basic level, at the level of the postgraduate study. So there is a way forward, and we are looking ahead for this coming year as well.
Thank you.
So thank you so much, Tamil Nadu Chapter IAG, Rekha ma'am, and all the office bearers for inviting me. Thank you, Divya, Damodar, Meenakshi ma'am, Mala ma'am, everyone. So today the topic given to me is the laparoscopic management of adnexal mass in adolescent age. So adnexal masses in adolescent, the incidence is less common, but still there are like 2.2 to 3 cases per 1 lakh girls. Usually they are benign, and most common are the benign lesions, and one of them most common is the mature teratoma, that is a dermoid cyst. Fertility preservation is a priority here, and that is why all the techniques to be learned to preserve the ovaries and the ovarian reserve, along with the laparoscopy, is being preferred in such a young girls, so that it should be the scarless and the minimal pain, and recovery is faster. The malignancy rate is very low, up around like 3 to 23%, and 0.9% all adolescent, that is 0.9% are considered to be the adolescent malignancy out of all. So 80% of the ovarian malignancies are the germ cells tumors. The other differential diagnosis, what are the presentations can be there with the different causes of the adnexal masses? There can be ovarian lesions, it can be functional cyst, or the benign neoplasms like dermoid, serous, or mucinous cyst adenomas. There can be a malignant tumors like germ cells, extraoral stromal tumors, or epithelial carcinomas, and they can present with the torsion. The tubal pathologies can also present as an adnexal mass, where the tubal ovarian abscess, though less common, hydrosalpinx, ectopic pregnancy, or paratubal cyst. There can be a vaginal or uterine abnormalities, Mullerian anomalies, or the hematometra, hematocolpus can also present as a mass in adnexa on ultrasound, and the GI other conditions like appendicular lesions and peritoneal inclusive cyst, or sometimes it can be the pelvic kidneys. So symptoms usually they present with the abdominal pain, which is one of the common cause, bringing them to the consultants, and the acute pain occurs when there is a rupture of the hemorrhagic cyst, or there is a torsion, or it can be because of ectopic pregnancy or the abscess formation. So nausea, vomiting can be associated with the pain, especially related with the torsion, and the abdominal distension, and other endocrinological manifestations such as precocious puberty or abnormal bleeding or amenorrhea virilization can be the presenting symptoms. Not going much detail into the investigations, but the basic investigations along with the pregnancy test And the tumor markers are important along with ultrasound, as we already discussed about the ultrasound in detail. So not going to such much detail into it, but the malignancy potential is less, but still one has to rule out the malignancy in this age group as well. So laparoscopic treatment is considered to be very safe, and there are various studies who prove that its role for the simple cyst or endometrioma and various other pathology. Laparoscopy is the preferred technique, provided the malignancy is ruled out. So coming to the functional cyst, which is common, non-cancerous, and usually fluid-filled sacs developed during the menstrual cycle, and it is usually 1 to 3 centimeter in size and dissolves spontaneously within 6 to 8 weeks, and often they are asymptomatic, so we do not need to do anything for them, and they may cause sometimes pain, discomfort, or may rarely rupture and can cause the torsion. Here, the studies suggest that the oral contraceptive pills, they do not hasten the resolution of this cyst, so usually we must restrain giving them, but may prevent it from developing the new one. Hemorrhagic cysts again are one of the common after the simple cyst. The expectant management is advisable here when the patient is clinically stable. Patient may have pain or can be managed medically with a simple diclofenac or maybe the paracetamol. Hematocrit is to be monitored in cases of the rupture cyst may cause the hemoperitoneum in these patients, and laparoscopy may require for this hemoperitoneum and the torsion of these hemorrhagic cysts. So para-ovarian cyst, it's a remnant of the paramesonephric and mesonephric ducts, and it can cause the pressure symptoms, and the laparoscopy is preferred here. So here is presenting one video how to handle these cases. It is a torsion. You can see the torsion of this is so gently with the two graspers you detort the adnexa and try to first you inspect the entire abdomen, upper abdomen, pelvis, the other ovary, and try to detort. You can see there's only a tube is isolated tubal torsion is there. Ovary is completely normal, and the infundibulopelvic ligament is stressed, which was normal. So there was a cyst in the mesosalpinx, which was the reason for her to have the torsion of this tuber, fallopian tube. So cyst was punctured, and different both layers of the mesosalpinx were opened gently, and this is the paraovarian cyst, which was held, and the cyst enucleation was performed. As it is not attached to any structure, usually we don't need any suturing or anything. We insert the scope inside to check for the hemostasis. It was completely blood-free area. And however, the tube was not looking so good, but still we left the tube intact, as it may gain the vascularity over a period of time. And being in such a young girl, we remain to be little more conservative. Now, another common lesion is the dermoid cyst. Dermoid cysts are sometimes missed in ultrasound diagnosis, being it's having the echogenic structure inside. So one has to be really very careful in diagnosing these lesions. The laparoscopic cystectomy has proven its role. It's very safe and effective. Only thing is to take care of the spillage of these material into the abdominal and the pelvic cavity. So what we do, we introduce the endobag first inside, and we try to engulf this mass around the like the endobag around the mass, so that whatever the spillage occurs inside the bag, because this can lead to chemical peritonitis if it is not properly thoroughly lavaged and the saline wash was not given. So after puncturing it at this certain point, we try to peel off the cyst wall. This is the 3 instrument technique. Well, the tooth grasper hold the specimen The atraumatic grasper hold the ovarian tissue, and with the central one, we try to peel the cyst without damaging much more to the ovary or the stroma and the epithelial. All content remain inside the endobag, can be easily taken out. So there is less chance of spillage. And it was taken out with the endobag through the secondary port or maybe the primary port. So adnexal toxin are again very common. About 50% of the benign adnexal lesion, they present with the torsion, and it really emerge urgent surgical intervention because if we like delay in managing such a torsion of the ovary can lead to the permanent damage to the ovarian reserve. So right side is much more commonly present than the left side. Maybe the sigmoid is protecting the left ovary for being a torsion. The mean diameter is observed in the torsion ovary 7.4 centimeter in certain studies. Detorsion and the ovarian cystectomy is the line of management. Even if the ovary appears necrotic at the surgery, we do not attempt to remove such a ovary. Even such a big mass. This is a case of serous cyst adenoma, previously operated laparoscopy, and again she has developed. So it was a detorsion at the level of the salpingo-ovarian pedicle. And once the cyst is punctured and the material is drained out, it is easy. However, the big the cyst is, one can still perform the cystectomy gently. It may take some time, but if you are in a correct plane, there is less chances of having bleeding. This thin wall cyst is difficult to pull, and the specimen removal can be done with the secondary tool. So there is always debate whether to detort the ovary first and or to just puncture the ovary and then do the cystectomy and then do the detorsion. But the various studies says that unknowingly leaving a malignancy behind is very minimally possible evidence are available. So it is very less likely in such a cases. Thromboembolic event after detorsion that the thrombus may dislodge and cause the embolism is also there is no evidence that supports such arguments, and there is no clear evidence that the benefit of oophoropexy after a single episode of torsion. So we remove the reason of torsion and we do not do the oophoropexy as per the guidelines for those who are having the single episode. Yes, for definitely we do for the repeated cases. So ovarian saving is the safe and it is preferred treatment for the ovarian torsion. The gross appearance of ovary doesn't correlate with the long-term ovarian viability and the function. Most salvage ovary will remain viable and even after the detorsion, and pregnancy have been documented in such a ovary, spontaneous pregnancy as well as the through the ART. But the follow-up imaging of the ultrasound at 3 months or maybe sooner if they are concerned about the malignancy, excuse me. So when the salpingo-oophorectomy is to be performed, salpingo-oophorectomy we perform only when there is a risk of malignancy or there is suspicious ovary where we have some doubts, so to get the frozen pelvis done and the for these cases, and for those who are having a long lasting, very necrotic and very gelatin like substructures in the ovarian ovary. So that is a totally necrotic ovary. So torsion in polycystic ovary is also common. Ovarian mass with a like that is more than 5 centimeter tend to tort because of the size. It may rotate. PCOS patient have a high risk of recurrent adnexal torsion. So in such a cases where we do not find any particular reason except for the PCOS normal looking ovary, there is no cyst or anything, then definitely we need to do the fixation of such a ovary because then they are more tend to develop the torsion again. So emergent laparoscopy with ovarian detorsion and even eventual bilateral ovariopexy is the preferred treatment. So acute lower abdominal pain in patients with PCOS should not be underestimated, and diagnosis should be made with ultrasound or CT MRI whenever it's required. So this is the case of very normal looking ovary. On ultrasound, we couldn't find out any cyst apart from a simple this collection of the hemorrhagic material in to less than 1 centimeter size. We also punctured those cysts, but there was nothing. And it was just a bulky 5 centimeter size ovary. Opposite ovary was also like big. And we just did this hot burn technique where we pass beneath the tube the suture material and we reverse it back as a box suture, and we fix the ovary. So here we did the both ovary fixation bilaterally with the round ligament. So ovarian ligament with a round ligament. So another rare case of the isolated fallopian ovarian torsion, there was a 7 twist of the tube where the ovary was normal, not affected. There was no discoloration of the tube, but still it may cause a painless amputation of this. And there was a small fimbrial cyst, which was maybe the reason of a twist, which was published in Minimal Invasive Gynecology Journal of America. So there are the giant adnexal mass, which are also teenager may also present with such a big size mass. The laparoscopic approach may be difficult here, but it is not impossible. There is a risk of rupture and because of the limited working space. The leakage of the cyst content may be the result into the chemical peritonitis or the dissemination of the cells. Although there is no significant of such a leakage and it's not controversial in benign lesion, but still one should avoid whenever the possible. So either we can introduce to the Palmer's point or the supra umbilical region at the epigastrium, or we can undergo with the 5 trocar and then eventually convert into the 10 One can also use the open technique at the umbilicus where you can visualize such a cyst and can puncture it directly. Once it is drained, it is like a normal size. So this is again a case of a young girl, unmarried. The diagnosis was the subserosal fibroid. Uh, we didn't do the MRI here, being it's a subserosal pediculator fibroid, but intraoperatively it was the solid ovarian tumor. So where we first initially thought being it's a solid, we just wanted to get the biopsy done, but then frozen section came out to be benign and we enucleated like a myomectomy. It can be a fibroma thecoma was a primary diagnosis. And it was easily peeling out like other cysts. And this also case was published into our journal. And we put this mass into the endo bag and then remove through the piecemeal inside the bag. Now, reconstruction of the ovary here is just by the approximation of the two edges with the bowel grasper, and the both will be, if required, we can take two sutures, but usually it will stick to each other easily. And it came out to be the stromal tumor, benign stromal. So even with the teen unmarried, one should not ignore about the one should not ignore the ectopic pregnancy when they present with the pain, amenorrhea, or maybe irregular bleeding, and should not hesitate to do the urine pregnancy test. If it is unruptured, can be managed medically or with the methotrexate. In a young girl, we usually try to prevent salpingectomy, but in case of very bad case of ruptured tube, one has to do the salpingectomy. So here we have performed the salpingostomy, removal of the pregnancy and the edges were clipped normal. It is unlikely to have the hydrosalpinx in young girls because of they are not sexually usually active, but it can occur in cases of Mullerian anomalies or the infections or maybe the any previous surgery, surgical bands or endometriosis and other sexually transmitted infections. So with the history of previous surgery or infection and should not miss this and it can adnexal mass can also present as a any Mullerian anomalies. So this can be the case of either bicornuate uterus or can be hematosalpinx or hematometra rudimentary horn. TO abscess are very rare due to PID in young girls. And the one of the common cause can be the tuberculosis can present with these kind of bad adhesions and the bad uh, pain, fever. It can also be after the MDP, which usually patients they hide the history of abortions and can few cases have reported with some GI disorders apart from appendicitis. There can be Crohn's disease. One of the few cases reported are due to the like poor hygiene and obesity, recurrent urinary infection can lead to ascending infection in such a patients and can also be managed very well with the laparoscopy. So malignancy here I'm not touching much, but it is approximately 10 to 30% of the all ovarian masses, accounting for 1% of the all childhood malignancy, 8% of the all abdominal tumors, and it is high suspicious malignancy. One has to perform the median laparotomy and the complete staging. But minimally invasive approach can only be done with the surgeons that is are experienced and properly trained, and there should not be no morcellation and the accidental rupture of such a thing. This is the accidental finding of these lesions on laparoscopy. So primarily we thought of this can be endometriosis, but then before proceeding further, we took this. It was looking like endometrial growth only, and we took this biopsy for the frozen section. And then there was all adherent tumor and other also peritoneal spreads were there already. So this was not looking so healthy. All tumor markers were normal here. So port side metastasis is also one of the specific challenging complications of laparoscopic gynecological onco procedure, which can occur 1 to 2% of all gynec procedure. And the cervical cancer, endometrial cancer are very low risk to having this port side metastasis, but it can occur with the ovarian cancers. Other causes of adnexal mass is like pedunculated subserous fibroids, which can present as adnexal mass and can easily be managed with the laparoscopic way. This is the broad ligament fibroid. So one has to see for the all the anatomy clearly, the ureter, one has to do the ultrasound properly to sight the location of the kidneys. So it was anteriorly as well as the posteriorly bulging mass. It is a pseudo broad ligament fibroid and managed easily laparoscopically. So one has to be careful about the bladder and ureter and the even the fallopian tubes and the ovary. Endometriosis, I was asked not to touch much of the endometriosis, so I am excluding this here because endometriosis requires completely entire 1 hour of discussion on the adolescent age. But this can be present, and we try to avoid as long as possible the surgery for such a young girl. But large endometrioma, and if it present with the symptoms like pain and other things, one has to undergo the surgery. But we try to avoid for the small asymptomatic myoma. We just keep them for the observation or on the medical management. And we counsel them to for the regular visits and the regular checkups. This is again a large mass, big fibroid. So this can also present with the abnormal presentations where the uterus was absolutely looking normal. It was a parasitic fibroid where the myomectomy was done previously, and the very large vessels like IVC size of vessels, and this is really a horrifying vision on introduction of the laparoscope inside, where there is a 20 to 30 centimeters of the fibroid size, which can also be managed laparoscopically well. So ovarian masses in adolescent and the pediatric can be like transabdominal or the pelvic ultrasound and the color Doppler. If they is suggestive of the simple cyst, no tumor markers usually we do. If the mass is less than 5 centimeter, just follow up on ultrasound 3 monthly. If it is more than 5 centimeter with the simple cyst, it's just a ultrasound diagnosis. And if it is symptomatic, then it can be a torsion. So then we opt for the laparoscopic approach of detorsion and cystectomy. In a complex cystic lesion may usually require surgery. For the solid region, all the tumor markers has to be done. CT, MRI, additional imaging has to be advocated, and depending upon the diagnosis, either radical or the laparoscopic approach. So space occupying lesion in adnexa can be of very interesting variety. Laparoscopy is the safe and preferred surgical technique for benign lesions in all ages. Visibility can be achieved even in a very huge masses you have seen, and the specimen retrieval can be challenging in many cases. So putting the bag and to remove the specimen from a very such a small size trocar site. So certain safety points have to be kept in mind while dealing with such a adnexal lesion, especially the diagnosis has to be. So thank you so much for giving me this platform here to share my few cases. But I'm so sorry that my throat is not so well yet. I hope I was hearable to all, audible to all.
Yes, thank you very much, Sejal. I think it was a nice talk with a whole variety of cases, and you somehow managed to speak with your throat like that. Thank you very much for being there. And I think she also dealt with a large number of cases. Dr. Jnanashankar, you want to say something? I think you're muted, Dr. Jnanashankar. So I think there are any questions now? Are
There
we?
are a couple of questions, ma'am.
Yeah, please. One is, I think I saw some 30-week size, large cyst, which is clearly benign. What should we do with it? Any of you can take that. It is because that's in an, I think, adolescent age.
Yes, ma'am, one has to rule out that the cyst origin, it can be mesenteric cyst, it can be pelvic, it can be a kidney, which is hydronephrotic kidney. So we cannot just directly puncture it based on the ultrasound findings.
Okay.
You put your scope inside, just inspect. And if you can't enter inside the scope, you use the open technique where you layer by layer open the abdominal wall and gently introduce your 5 trocar, and then you have a vision of the entire other like bowel and mesentery and all. If you're very sure it is ovarian, then definitely you can puncture.
Yeah, very often the very large size may be paraovarian cyst because
Yes.
paraovarian cyst can actually attain a large size like this, 30 weeks, etc. There can be. So one differential diagnosis is that, or you can have a mucinous cystadenoma. So these should be identified by tumor markers. I think otherwise you can try. The other thing which could happen in an adolescent age group is ACUM. The I mean, the scan diagnosis will be a Adnexal cyst, but it can also be an ACUM.
Yes,
So
ma'am. I have not touched
touch
the
upon that.
Mullerian and the endometriosis.
Yeah, that's
Just,
okay. Yeah.
yeah.
All right. Any other questions?
The other question is, can we aspirate the huge cyst in lab before proceeding? Does it upstage the disease because there may be a spill due to its size?
Already I have answered that, better to diagnose it first. But a spillage, as per the studies, they for these benign cases, it doesn't change any upscaling. But still, we try to avoid as far as possible. So what we do, we introduce either directly under vision the secondary trocar in and then suck it out the all material, so that, and with the other port we hold the edges of the trocar so that it will not spill as far as possible.
I
But
think also based on what the previous speakers have spoken about risk malignant index and ORADs and things like that. Based on that, if you think that it is malignant, then
then
maybe you
definitely,
go.
if it is highly suspicious of malignancy, directly go for laparotomy in such a
Yeah,
cases.
yeah,
If it
yeah.
like then otherwise you can put for other cases you can put for frozen section and then you can.
Yes. Yes. And I think last question is, do we do markers if ultrasound shows dermoid cyst?
No, usually we do not do markers for the ultrasound, provided the ultrasound is good enough, in a good hand. We do not do. And we do not follow also. Intraoperative finding, if it is something different than your ultrasound finding, then definitely you are in trouble.
I think this is for the first speaker. I think what all tumor markers should we do in postmenopausal ovarian cyst other than CA125, CA and CA19-9?
If the imaging is suggestive of any germ cell malignancy, we can do other germ cell markers like alpha fetoprotein, LDH, and serum beta HCG. Other than the CA19-9 CA for to diagnosing GA malignancy to the secondary metastatic ovarian tumors.
Okay, thanks. Thank you. Dr. Divya should be, sir is also here. Good evening, Paul, sir.
Good evening, sir. Good evening.
Good evening, sir.
Good evening, Dr. Paul.
Good evening.
Okay.
I did
So,
not join early.
Yeah, nice to
No
see you,
problem.
sir. Yeah, thanks. I think you're on time, so should we proceed to the panel?
Yeah, definitely.
Divya?
Yes, sir. Good evening, sir.
Good evening, Divya.
Nice. Yeah. So we know how to deal with the various cysts. Now we are here with the clinical scenarios where we've dealt with certain complicated cysts. We've done some. We've had some complications and how we have managed them. And is it safe medico-legally, as well as what specific consents is what we are going to discuss in this panel. So we have Dr. Paul sir, Dr. Rekha ma'am as our expert leaders who will guide us through the entire panel discussion. I have Dr. Karthika of GEM Hospital and our panelists Jnana Shankar sir, Dr. Aruna, Dr. Kavita Sukumar, who is a oncologist, gynae oncologist from Chennai, Dr. Damodar Rao from Coimbatore, who needs no introduction. Dr. Tarun is yet to join us, and Dr. Sundar Narayan, is he there? Oh, he's yet to join. And I request Prasanna also to join the panel. Yes, sir. So the idea of this panel here is to answer certain questions regarding the technique of how we do cystectomy, how to get clearer planes, how to retrieve the specimen, and how to contain the spill. And also certain major decision-oriented dilemmas of when to do a laparotomy and when to shift from laparoscopy to laparotomy. Are there any indicators? And when to do salpingo-oophorectomy and shy away from cystectomy. Any specific consents in these and what are the medico-legal safety? Kartika, would you like to start with the first case?
Yes, ma'am. I'll share now. So this is the case scenario 1, and I think this is what the last discussion of the last, it was the final discussion that happened with Madam also. But again, this was the first case. So we will discuss this way. Miss Y, a 22-year-old, came with complaints of abdominal distension and mass since the past 4 months. She did not have any abdominal pain, no other symptoms. She was evaluated.
Did we just lose her?
Yeah, I think we lost her.
Well, but that's her laptop, is it? She's sharing from.
Yeah, she's doing it from her.
Better go with the next case.
Yeah, we
Yes,
can.
sir.
Divya, we can.
We'll go ahead with the next case, sir. So we have a 26-year-old.
You have to share your
para
screen.
one.
Share your screen.
Yeah, yeah.
Yeah, can see your screen. Just
Yeah.
full screen. Yeah, yeah, it's come to full screen, I think. Yes, yeah.
Yeah, so we'll go to this case, who's a 26-year-old para one, living one, and she has a vague lower abdomen pain. She has regular cycles and normal flow. The TVS just shows a thin, clear-walled, multiloculated cyst with no solid areas, and it's just 8 centimeter size. She is desirous of fertility, and all the tumor markers are also within the normal range. So this is a simple, straightforward case which we usually see in our OPD. We went ahead and because there was no suspicion of any malignancy or anything, we do it the usual way because it's a thin walled cyst in one particular area. This is my usual technique of to avoid spill and to put a secondary trocar directly into the cyst, completely aspirate it, and go ahead with the cystectomy. If this was a bigger cyst, would we do trimming or would we directly proceed to cystectomy, sir? So the panelist, Dr. Damodar, sir, is it necessary in a bigger case to do a trimming of the cyst or to straight away
Yeah,
proceed
if
to
it's
laparotomy into the
really huge, I mean, not like this. If we find it very, very huge and some areas are like, I mean, there's hardly any ovarian tissue. It's thinned out so much. Maybe those areas you can de-roof it and then start doing the cystectomy because I don't know if there's much that's going to really impact our ovarian reserve. But a case like this, I think you can directly, go ahead and do cystectomy. But as much as possible, try not to lose any ovarian tissue because she's planning for fertility.
Yeah, and we have specifically seen certain trabeculation inside this ovary. Not papillae, I would rather say certain trabeculations, and the cystectomy was difficult. How will you address the hemostasis here, sir? Shankar, sir?
Yeah, so any coagulation there is going to have some impact on the ovarian residue. So small vessels often they stop with your pneumoperitoneum, or by waiting it just stops a small wound. So we don't need to take every small bleeder, but anything which is significant, soiling the place, obvious spurters, spot coagulation is what we would advise.
Yeah. So will vasopressin help us, sir, to have a clearer field, or the spot coagulation will help us better?
And often after completing the cystectomy, good compression of 3 to 4 minutes would actually stop many a bleed and also oppose the cyst wall together by compression.
Yeah, opposing the cyst wall together with a large, long intestinal grasper forceps usually helps us to, attain hemostasis as well as oppose the edges together. As we saw towards the end of the cystectomy, I've trimmed this area. I couldn't proceed any further beyond this area. There was, it was very difficult near the hilar area to do cystectomy in this particular patient. What can we do here, sir? This is something which we face regularly. Like we've encountered one or two dermoids also, wherein the solid area is right there sitting at the hilum and we're not able to peel it. We've removed it. How to address the hilum area and the insufficient peeling at that area? Any technique you have, sir, for that? Jnana Shankar, sir?
So, no, it is a balance between leaving live tissue back, pathology back, or saving the ovary. But I'd always go and address the pathology first, even if it means we'll have to lose 1 second.
Okay. So yes, so we are done with this patient. And because there was bleeding, we took extra care, apposed the edges together, and then we were done here. So in this case, is there any need for a staging? It's a straight cut case. I don't think it's not needed.
No,
Yeah.
not required.
Post-operatively, the histopathology came out.
Yeah, the decision on whether we need to go for staging, all that has to be a preoperative.
Preoperative.
Yeah. So in MRI only, we need to be really sure that what are we dealing with. At any small doubt of holding a malignancy, we wouldn't need to be, we shouldn't be going like this. No cystectomy.
Okay. So it was a case of serous cystadenoma, benign serous cystadenoma. So I knew intraoperatively itself that the cystectomy was a little bit imperfect. And yeah, so the patient developed a high-grade fever and there was an ovarian collection on ultrasound up to 4 to 5 centimeter with a very raised CRP on day 14. Sir, what is your suspicion? Who else is there in the panel? I think Dr. Kavita ma'am also is there. Ma'am?
Could we have your screens on, please? Whoever is the panelist, the
Yeah,
other
panelists,
panelists?
whoever is there.
Yeah, Divya, see, my first question is, when 8 centimeters cyst is a borderline cyst. Now, if this was a persistent cyst, if she's had a scan done previously and it has always been there, then I would have probably chosen to do a surgery, or if she was symptomatic. Otherwise, you can also wait for a few months, and some of these cysts could be functional as well, and they may disappear on their own. No, 7 to 8 centimeters cysts are kind of borderline. So I feel that no, that you have to look at these records and see if the cyst has been persistent for some time. No, just for you to know that, whether you really have to go ahead and do surgery when you look at all the cysts on ultrasound. So that is one thing. Reproductive age group. She's got one child now, and if she's not too keen on pregnancy immediately, and if she is asymptomatic, then I'd probably wait for a few months, put her on ocipil to prevent another cyst to occur, and then you can discuss these with the patients. Now once you developed a fever and this collection, it needs to be drained. You can take the help of your radiologist, and it's probably pus there, and you could probably aspirate that and put her on higher antibiotics.
Okay, so that's what we did. We gave antibiotics, supportive care, because she had high-grade fever. And what would you do? Would you do a relook laparoscopy or a TVS guided aspiration? Which one will be better?
I think you have to address the particular panelist, no? Because this is in Zoom. So you kindly mention who.
Yes, sir. Jnana Shankar, sir. Yes, sir.
Yeah. So now recently we had a patient like this. That was an ovarian abscess which developed after hysterectomy. Nothing was done for the ovary, but patient developed a primary ovarian abscess following hysterectomy. So what we did was we found that it was a single abscess in the right ovary. So only mere drainage may not help. So we put in a CT guided pigtail catheter and then allowed for drainage, and with the antibiotic course of 14 days it subsided. Then we had another patient who was operated outside, similar scenario, but that was a multiloculated abscess. So in that case, we felt CT guided drainage wouldn't suffice. So there we went and put in a laparoscope, and then we gave a thorough lavage, and then after that she subsided. So select localized single abscess, maybe ultrasound or CT guided, but it's better to leave a drainage and come rather than one single simple aspiration.
Okay. So exactly 1 year later, the same patient had a recurrence, and this time it was bilateral. She had a 18 centimeter size cyst in the same side where we operated, and she developed another 6 centimeter cyst on the other side, which is also likely benign, is what they gave us. Damodar sir, how will we proceed? Should
Well,
we?
again, if if you think it is benign, then definitely go by laparoscopy
Yeah.
and operate again because she's young and you need to preserve her fertility. Maybe on this side you could do partial oophorectomy. If I could, I don't know if that's a term, but I think that's a term that's used now. You can maybe reduce the size of that particular ovary, and on the left side do a cystectomy as usual. Some people would also argue that they might want to take out the right ovary completely. Uh, that's completely dependent on in that 1 year, did she conceive, not conceive, what is her AMH at this point, all that you got to look into. And based on that, I'll take a call.
Yeah, so because she wanted fertility and because she insisted us to go ahead with a laparotomy because she wanted a complete cure on the right side, we went ahead, did a laparotomy for her in spite of us counseling her so many times that still laparoscopy will help for her and a cystectomy would still be enough on the right side. So, but she insisted and we went ahead and did a right salpingo oophorectomy and a left side cystectomy. And once we have done this, what can we do to prevent the recurrence, Yanashankar sir? Can we give oral OCPs, oral contraceptive pills for her to prevent a recurrence?
Just to start with, Divya, you had asked me one question before, what to do with the cyst wall which is adherent to the ovary. So
Yeah.
what technique? So that is where we had, that's where we had problem with this case, I think. So when
Yes.
you leave behind the pathology, that naturally expect it to recur somewhere. So in that case, we have to decide between whether it's a pathology or the ovarian reserve. We might have to go for the pathology and resect the pathology so that she doesn't have a recurrence. Only functional ovarian cysts are the ones that you can decrease by giving oral contraceptive pills. Number one. Number two, of course, by giving oral contraceptive pills, you can decrease the risk of um, uh, even the lifetime occurrence of ovarian cancers. But all other ovarian cysts, I'm really not sure. Even borderline ovarian cancers, you can't prevent by giving contraceptive pills. Only thing, maybe this patient we could have had her on a closer watch rather than doing an ultrasound after 1 year. Maybe if we think that we had left behind some portion of the cyst wall, maybe after 6 months, a repeat scan would have maybe been beneficial. That's my point of view.
Yeah, she was out of station. She was there with us for 3 to 4 months. Then we lost her to follow up. But anyway, she came back to us for the surgery again. Yes, sir. So, Paul, sir, do you have any advice to us, sir, on this? Whether we could have done the cystectomy a little better?
Also, he was.
Sir is not here.
Dr. Divya?
Yes.
So you are also telling about some irregularities, some small papillary projections, which you see, Often
Yes.
we find that report in the histopathology as the fibroma component of that. So you'll often find cystadenofibroma, serous cystadenofibroma. Okay, those questions. Often they give us a scare thinking whether we are dealing with malignancy. Intraoperatively, when you see small nodules inside the cyst wall, no? We often get scared whether so they are part of epithelial malignancy, but often the final report comes as cystadenofibroma.
Yeah, so we see certain cases, we see these kind of things, not papillae exactly, or a kind of a trabeculated and intra-bladder kind of appearance. I think that's what this cystadenofibroma is what you're describing, sir, over here. Okay, so I think we've had a discussion about how to go about it, and still cystectomy is valid in this patient, still LAP is valid. And because it is a reoccurrence, we always have to err on the side of the pathology and remove more of the pathology rather than giving her some more, one more recurrence.
And one more thing, I think I don't think cystectomy by laparotomy would do a complete job. I think the vision in laparoscopy is so much better. I don't know. That's
Yeah.
my take. I don't know if laparotomy will help you do a better job at cystectomy.
Not at all, sir. But that's why I insisted the patient wanted, I know they fed her with
Yeah.
the idea that laparotomy would have been better. But we were happy that even with that idea, she came back to us rather than so we had to go ahead with the laparotomy with her. Yeah.
I think that would actually cause more problems for her fertility in future, an unnecessary laparotomy, I think. But I mean, for curative, okay, I agree. But I think for such cases, if it is very thin and not, cyst wall is not possible to remove that little bit of ovarian tissue. That is probably better, right? This is what my take is. You have to, if it's not separable, take off a
Okay,
little
ma'am.
bit of the ovarian tissue also. It
Yes.
is okay.
Yes. Absolutely, ma'am.
That's
Trim
what
the
I feel.
pathological area. Yes, ma'am.
Yeah, trim the pathological area and send it off, so you will not have, to do a laparotomy and like that. Is what I feel.
Okay.
Especially, I mean, I think ma'am, I don't know, what is your take on that, ma'am? And Divya had asked, if you have a solid looking area or that cyst wall which is inseparable at the hilum, then what would you want to do, ma'am? Rekha, ma'am.
You are talking to me. If it's at the hilum.
Yeah.
Yes, ma'am.
At the hilum, if it is not possible, then cauterize that area. You have to cauterize and destroy that area. Because if you feel that is, looking abnormal, looking not so good, then it's probably good to do that. Is what I feel. But remove the mass is probably better.
Yes, ma'am. Thank you, ma'am.
Yeah.
Yes. I had one more, Rekha ma'am, I had one more
Paul sir
same
is
kind
also
of
back.
case.
I think Dr. Paul is back. You can ask.
Sir, hi, sir. Yes. The patient had recurrence, and that was what we were discussing, sir. So sometimes if we see this hilar area, if it has a solid, like for example, in a dermoid cyst, the tooth part or the cartilage part or the bony part, sometimes it is there and stuck at the level of the hilum. Then how do we address that area, sir?
We see occasional patients where it is up to the outer surface. Then we have to compromise that area and excise completely. Because leaving behind, we are not sure, no. The chance of recurrence is quite high.
Yes, sir. So I think it has been a unanimous decision everywhere that don't leave behind pathology, because in ovary, usually when we leave behind a pathology, the secretory part, or we don't know why, we have more recurrences. So it's better to get rid of the pathology, err and trim on the side of the ovary rather than leaving behind the pathology.
I think only exception to this rule would be in endometrioma, where they say that you can leave a little behind the cyst wall versus going and tugging at the cyst wall at the hilum, and then you would further cause burning of the hilum because there's some bleeding, then you will cause a fall in the ovarian reserve. And anyway, I think endometriomas are known to recur. So, and if they recur, you're not going to go back and do a oophorectomy for that patient. So maybe compared to other cyst, endometriomas may be a little different.
Okay, let's go to our next case, sir, now. We have a lot of discussion with Kavita ma'am. Ma'am, are you here?
Yeah, I'm here.
Yeah. So she is a second gravida 2 abortion 1 patient. She's 28-year-old. She's married since 3 years. I hope the screen is visible, sir.
Yes,
Screen
yes.
is-
Yeah.
Yeah. So she's married since 3 years. She's
It's
been
not on full
evaluated
screen, I think.
extensively. It's not on full screen?
Mm.
Okay, 1 second. Yeah.
Yeah.
So, yeah, we've been evaluating her for secondary infertility, and she also gives us a previous history of laparoscopy for a simple clear cyst. And on ultrasound, she has one side polycystic ovary, and the other ovary has multiple echogenic projections with thin septations, non-shadowing calcific areas, mucinous, and they gave us a doubt of whether it could be a dermoid still or a mucinous cystadenoma. We suggested that we involve the gynae oncologist also. We suggested we would go ahead and do a laparoscopy as she wanted a laparoscopy, and the tumor markers were within the normal range. Considering the ultrasound finding, Kavita ma'am, would you give her any specific consent about cystectomy in bag, or any chances of oophorectomy that has to be explained to her, Kavita ma'am?
Yeah. See, this patient, the only issue comes when the patient wants fertility. So that is the only time when it becomes really problematic. Now, I'd like to see the imaging myself. Now, ultrasound is not going to be enough in this case because they've reported as a complex ovarian mass and it's all very vague. They've written some echogenic projections. They're not even sure whether it's a dermoid because some you've written it as that there are non-shadowing areas, but there are some projections there inside. Now, ultrasound is very, and not mention about any vascularity. So ultrasound kind of is incomplete. Now, the most important thing that you'll have to, see before you do surgery or embark on surgery is your imaging. Yeah, because especially in these cases, now 28 years, you can have all sorts of malignancies. It's not that we don't see malignancies in these age group. We've seen all high grade, right from high grade serous cancers to low grade serous to germ cell tumors. So all of these can happen in this age group, even metastatic for that matter. So it is very important that your imaging has to be properly reviewed. So ultrasound is definitely not enough. Even if the tumor markers are normal, you have, when there is a complex mass with some projections inside, you always have to have malignancy in your background. So MRI, definitely I would have done for this case, and look at MRI features. And if it is suggestive of something like a dermoid kind, then it becomes a little easy. Now, if an MRI again shows areas, solid areas inside with diffusion restriction, then it becomes a problem. So that MRI is going to guide your management. So if MRI is suggestive of more of a benign kind of etiology, then you can plan ahead. You can go ahead with cystectomy. But if the MRI is suspicious, or if now in this case tumor markers are normal, so supposing tumor markers were elevated, so if you have a clinical suspicion of malignancy, I could probably go in with a laparoscopy, but then I will convert, if there is a suspicion of malignancy, then to do the procedure itself, I would not do it under laparoscopy. I would have preferred to do an open surgery. You can start off with a DLAP, look for peritoneal disease and disease outside. If there was a suspicion of malignancy, then I would have done a laparotomy. So that's how I would have done. And yeah, so
the next slide is not going to agree with you, ma'am. So what
I
is the
think
opinion
over
from
here, could we have
Dr.
gone for an MRI
Damodar
before?
and
I would have asked for an MRI before going in for,
so that gives a lot of information, especially in the context of fertility preservation. And it's not only an MRI you write and then you get the report. You need to talk to the radiologist who's reporting the MRI, because you need to know exactly what it is. What are the contents inside, whether there is fat, whether there is blood, whether there are solid areas with diffusion restriction. Now, all of these you must know before so it's very important that you talk, not only do an MRI, talk to the radiologist before you embark on surgery.
okay,
Yeah,
ma'am. Yeah. So we went ahead. Okay. Screen sharing.
Screen is seen already.
Yeah. Screen is seen. Yeah. Yeah. So this is the intra-op picture. This is because of a little bit of addition from the previous surgery. So there was a bit of addition underneath. We released it. We were worried that we're not able to do in bag because of the addition. And was nicely stuck underneath. We went ahead and to our surprise, we found, not surprise, as we expected, we found a little bit of these papillary projections. We teased it out from the pelvic side wall. And because we had already spoken to her about the chances of salpingo-oophorectomy, in spite of her wanting fertility, they did not want to go ahead with preserving the ovary. We went ahead and did a salpingo-oophorectomy. I know still cystectomy would have been possible in this patient. Ma'am, is this decision right? Should it have been salpingo-oophorectomy? Should it have been a cystectomy? How would you go about with the decision?
This kind of appearance, no, you could have definitely made out even by the ultrasound. No, nicely you can make out that solid component inside. No, it's not it's not one small papillae here and there. You have one big bunch there. You can see that. So this kind of appearance when you have in a preoperative imaging itself, you'll make out the size of the solid area, the size of the papillae counts. Now, when you have very small 3-5 mm and few here and there, just a few papillary projections. Now, I'm sure Anusha would have told about this ORAS categorization. So when you have just a few of these papillary projections, then your chances of it being benign or maximum borderline is, that is maximum that it will you will get. But here, this kind of, solid components which are more than 1 centimeter, 1 to 2 centimeters in a focused area, it can be anywhere between a benign, it's obviously a serous tumor. So anywhere between a benign, a borderline, or sometimes it can also be a low-grade serous carcinoma. So if you have this kind of, larger papillary projections, then I would have proceeded directly with an open and salpingo-oophorectomy. So that is what I would have done. Not even
one doubt in this. Yeah, I agree with you. The open salpingo-oophorectomy would have been better. But because she had additions, I'm not telling that you should have expected this earlier because she had the additions. Anyway, even if we do an open surgery for her, anyways, when we do release the ovary from the bed, there would be some amount of spill, right?
No, you can't do it without spill. You can do it. This does
little bit that adhesiolysis that was really stuck at the base.
I'd like to beg to differ from. I'm the only odd one out here in this entire forum, I think. But see, in open surgery we use loops. Okay, so it is you can get that kind of magnification in open surgery as well, and you can go into the proper plane, and you don't. This kind of things doesn't spill in open surgery, so it is you can definitely do it without spill. Okay. So that's how I would have managed. Okay. But, there can be a difference of opinion, but, I kind of feel that you have to err a little bit on the safer side. So that's how I would have gone about in this case.
Okay. So,
Divya, Dr. Nyan Shankar.
Yeah.
So certainly we are here to learn from each other and learn from others' mistakes also. Because all of us, so many people are watching us, the clear message from here is whenever there is a doubt, when the ultrasound is ambiguous and they are not clear, it is better to go and do an MRI. Actually, for picking up dermoids, even ultrasound is a superior modality. When an ultrasound has got a doubt whether it is dermoid or epithelial tumor, like the report that you had here, certainly she warrants to have an MRI done. Okay. MRI again has got very high sensitivity, specificity for dermoids, more than 98% like that is the sensitivity and specificity. So that's the first thing. Second is whether rupture would come by open or laparoscopy. So each of us are going to have our own agreements, disagreements. So far, among the available papers for laparoscopy for primary staging of CA ovaries, they found that adhesion and size is the highest risk factor for rupture. So, tumor which is adherent, like what you showed in this, no, there is a chance that, yeah, still in spite of our best hands, maybe apart from Kavita, we also can, we also can rupture it by.
This additions is it was not
Yeah.
so
So as you
severe, but
said,
see, I agree
not
if
the
it was
case specific,
endometriosis.
the
If
general
it was,
idea we should get.
yeah, if it was an endometriosis, definitely there is a chance of spill. Now, I agree. No, those kind of additions are different, but this was not so. It was okay kind of additions.
Second surgery, no? Second surgery on the same ovary.
Yeah.
So, yeah, additions like, so those of us who are doing laparoscopy day in and out, bread and butter would say, no, by laparoscopy, I can actually try to find a plane without spill. So that slight difference between Kavita and us.
The thing is, like, sir, like if you really, the patient, supposing the patient really wants a laparoscopy, then I would have, what you could have done is you can release these additions without spillage, go in one plane, outside, remove the entire ovary, put it in a bag and remove it. You can, but
That
the
is possible.
idea is you have to avoid spill. That is the most important.
If we had attempted to do a cystectomy, certainly there will be a spillage in cases like
Yeah, exactly.
Yeah.
now that you have decided for a oophorectomy, maybe you could have avoided a spill. That's
Yeah. So next thing which we all think about here in this case is what is the role of frozen section, ma'am? Kavita, ma'am?
Yeah, so basically, when you have see frozen, generally when you talk of frozen and ovarian masses, the sensitivity is not bad. It is like you can get for 80 to 90% sensitivity for general ovarian masses. But your frozen is not so, it's got a lot of error when you are dealing with mucinous tumors. So mucinous tumors, generally you will have to depend on final histopathology, your imaging, your grossing, frozen, all of this will, you cannot differentiate. Even if you cut it open and see nothing, you can only depend on final histopathology. So leave alone mucinous tumors. For the rest, you will be able to, get an idea of what you're dealing with. But when in the context of fertility preservation, like this case, now, let's say the patient, you sending this for frozen section, and they will give you a report of query suspicious for malignancy. Now, are we going to go ahead and do a hysterectomy based on that report? Now, it is so difficult to do radical decisions on a patient who wants fertility based on a frozen report. So, when a patient wants fertility preservation, I generally, I talk to them and tell that in case needed, we will go back and do a second surgery. A lot of times, you can, because this most probably it will be a benign or a borderline serous tumor. If it comes out as low grade serous carcinoma, you can go back and do a laparoscopic staging. It is still possible. So, because it will depend on so many things. It's not only the histopathology, then they'll have to put IHC on it. Then only they'll come with a final diagnosis. So, in the context of fertility preservation, I usually use it, very sparingly. But in case the same patient, if she's completed family, now she's got 2 children, she's completed family, then I will send it for frozen. Now, supposing it comes out as borderline serous tumor, in that particular case, then I would have discussed preoperatively itself what you want to do to the opposite, because you know that the other ovary can be involved. There is a percentage of involvement. So I would have discussed with them whether they want a complete surgery or they want a follow-up. So the role of frozen section will depend on number one, if she wants fertility. Second, doesn't want fertility, young age, whether she's completed family. Third is the other group where the patient is perimenopausal, postmenopausal, where definitely I will do a frozen. Based on the frozen, I'm going to proceed and manage accordingly. So that's how I generally go about.
So this patient wants fertility, ma'am. So we should take frozen section with a pinch of salt. We always want to get the final diagnosis.
You tell them beforehand that based on the report, you may require a second surgery. So that is a better option for them.
A better option. Yeah, exactly. So
I just had a question. In case you're going for a oophorectomy, would you? What's the role of not oocyte but tissue, ovarian tissue cryopreservation? Any experience with that? Madam, sorry, I didn't get your name.
No, sir, ovarian tissue cryopreservation, see, this patient is just, she's got a unilateral ovarian mass, and the other ovary is normal, and the final report is only serous borderline tumor, and you're going to keep her, she can start conceiving, or you can, I mean, you can start off fertility management immediately in the immediate post-op period. So
Not this patient, but generally.
yeah, generally. Now, generally, we advise oocyte cryopreservation when these patients come with bilateral ovarian masses. So, if you've touched upon both the ovaries, bilateral cystectomy done, or one side oophorectomy, one side cystectomy done, the ovarian reserve is going to drop down. And I also suggest, this kind of oocyte cryopreservations for dysgerminomas. Or in young girls, because dysgerminoma again has got a bilaterality rate. So those kind of patients, when both ovaries are touched upon, it's always better that some kind of, it's kind of an insurance. We suggest at least an oocyte cryopreservation. If the patient has got a partner, then embryo cryopreservation is best. Now, if the patient, you need to give her chemotherapy for some reason, then we can, it depends, no? It depends on what kind of tumor and all that. Now, if it's a germ cell tumor and you need to start them on immediate chemotherapy, then we don't do anything right away. We finish off the 3 or 4 cycles of BEP, give them 6 months gap, and after 6 months, then you can suggest them this oocyte cryopreservation. So it can be done if they are unmarried, or if they are married, you can do an embryo cryopreservation. So if the patient is like, there is no chemotherapy given, and then you can start off, immediately afterwards. Just give them time for wound healing, and then you could, it's a good practice to, offer them this, some kind of oocyte or embryo cryopreservation, especially when both ovaries are touched upon. Or if the tumor has got a propensity for a bilateral involvement, like for example, a dysgerminoma or a borderline serous tumor, or even sometimes a benign serous tumor, these have 20 to 25% bilateral risk. So it is, even dermoids for that matter. We've had patients who had a torsion, one side ovary removed, and 2 years later, the other side ovary had come with torsion and both ovaries removed. At 25, she's like premature menopause. So these kind of situations also do happen. So when, even for ovarian dermoid cyst, when you've done bilateral cystectomy, so when ovarian reserve is a question, it is always a good practice to suggest these two things to the patient. That's what I feel.
You're talking more of embryo or oocyte, but ovarian tissue cryopreservation.
Yeah, tissue cryopreservation is not done. So I've done a few cases, sir, but the success rates is not as good as of now in India. Now, I had one patient who had an 24-year-old girl who had an endometrial stromal sarcoma of the uterus, which is involving the ovary. So we had to do a completion surgery. One ovary was normal, and we didn't have time for, it was a very fast growing kind of tumor. So at the time of surgery, we did take ovarian tissue, and then we cryopreserved it. But the success rates are not as good as your embryo. Embryo is the best. Then next comes oocyte, the oocyte cryopreservation. The third is your ovarian tissue cryopreservation. You could do it if you don't have time, and the patient is prepubertal, or just attain menarche and all that. So that kind of tissues you could offer them, but the results are, I think, not so good.
What about the problem of transmitting malignancy?
Yes, madam. So they do a histopathology. So they cut it into different, pieces, and they look for, but the biopsy is all done, and then only they freeze it and keep it.
Cryopreserve. Yep. I agree.
So definitely we'll be doing a staging also along with this. Dr. Tarun, I think he's joined us in the panel. What all goes into the staging of this? Can we discuss on that, Dr. Tarun? Is it?
Hello. Sorry, I had joined from the long link. I was watching the entire panel from the delegate link. I'm so sorry.
Yeah.
Yeah. So staging, I think first thing is we're going to look at the other ovary. I'm sorry. The question was for this case.
Yeah, for this case.
Okay. All right.
Because we had a suspicion.
So if we are thinking of a malignancy, I think first of all, I think everybody had already agreed it had to be an open case. But anyway, for this patient, first thing we would do is look at the other ovary, look to see if there's any spread or any possible tumor lesions on the other ovary. We would also look at the rest of the abdomen, the peritoneum, any seeding, any deposits that we are seeing there on the peritoneum, the rest of the abdomen. Look at the omentum, look around the liver and the other organs for any possible other deposits that we're looking for. And yeah, I think that would probably cover the entire this thing. Whether it is open or laparoscopy, I think depends upon your own standard and ability of doing the case.
Yeah. So we inspect all these areas. We do take some peritoneal lavage fluid. We do want some peritoneal wall biopsies, and also we need some momentum also for a biopsy in order to complete the staging in the first sitting itself over here. So that's what we have done.
Ideally, the
And
peritoneal lavage should be taken before you've done the
before,
oophorectomy, I think.
yeah,
So
before
that should be
doing the
starting off the
procedure.
entire thing. Yeah.
Yes. Yeah. So, so for it came out, the biopsy came out as serous borderline tumor. So, borderline tumor is a histopathological diagnosis wherein there is no stromal invasion. So, even in these borderline tumors, staging is important, because today only I spoke to her, then I realized that yes, we have to understand the point that the term borderline just refers only to the histopathological diagnosis. So staging is important, like how we have CA ovary stage 1, 2, 3, 4. We have the same thing for the borderline tumor also, like stage 1, 2, 3, 4. Sometimes these borderline tumors may have peritoneal deposits which are invasive. So there comes the importance of taking that omentum for a biopsy, taking peritoneal wall biopsies and a proper lavage, okay, so that we can stage the borderline tumor also. So the treatment pathway in serous borderline, mucinous borderline, and in endometrioid borderline is totally different. They treat the mucinous borderline a little more aggressively, and serous in general usually is sometimes bilateral. So we have to treat according to the fertility requirement. So we did discuss about the role of Rosen section here. The concordance rates between the intraoperative report and the final report which we receive later on is only about 66 to 73% in these borderline ovarian tumors. So when they do need fertility, as we said, we can't take a decision based on that, because there is a higher incidence of underdiagnosis also. And even if we overdiagnose, we cannot go ahead and do a primary hysterectomy and bilateral salpingo-oophorectomy in this patient who needs a fertility. So borderline is just a histopathological diagnosis, and the staging is similar to any CA ovary. And restaging and completion surgery is definitely needed if the first surgery was the staging was not done, or we don't have adequate information. So, ma'am, in borderline tumors, can we give OC pills?
No, just before that, see this first, when you got a report of borderline ovarian tumor, serous tumor, it is very important that you get an oncopathology review to make sure it is number one borderline. And you have separate variants of borderline tumor. You have something called a micropapillary variant, which is more aggressive, which has got a more higher propensity to recur. So we'd like to know if it is that kind of tumor. And generally, if it is a micropapillary variant, we probably say, no, just to go back and remove that omentum. It is a little controversial whether we go back and do the staging completion surgery for a regular type of borderline ovarian tumor. You could do, I mean, it's not always done. That is what. So the idea is to you do it upfront, but sometimes they are referred after, if they've done a cystectomy and you think that there are the disease is left behind, then we go ahead and do. If it's a micropapillary variant, you go ahead and do. If the imaging is suspicious, you have something outside the ovary, then these are indications for restaging. Now, for this patient, she wants fertility, right? So after wound healing, you will send her for, I mean, you conception naturally or whatever means artificial. So that can be done. Basically, these patients, if you think that she doesn't want fertility, she's already got a child, or she's not thinking of fertility right now, then you can put her on OC pill. It's not a problem. Basically, these borderline serous and even sometimes mucinous tumors are hormone receptor positive. So, but in case of an advanced, like you said, this when you have these implants outside, and so meaning that it is an advanced type of borderline ovarian tumor, So then predominantly the role is surgical. So you need to go ahead and remove all those implants because they don't respond to chemotherapy. Sometimes we put them on hormone therapy also after complete removal of these implants. So when you have these advanced borderline ovarian tumors, then hormone therapy is contraindicated in any form. Ocipil, or if you remove the entire thing, HRT, all of these are contraindicated in an advanced borderline ovarian tumor. But otherwise, you can put them on contraception and that's not a problem.
If they've done a cystectomy for the borderline ovarian tumor, do you go back and remove that ovary or?
Sir, it depends. That's what I told you. If it's a micropapillary variant, the risk of recurrence is very high. Now, it in the order of some 40 to 50% also. But even otherwise, 20 to 30% will recur. No, you need to explain the risk to the patient. Now, so if there is no life risk, there is no survival which is altered, but there is a local recurrence which is possible. So these things will have to be discussed with the patient because you can't keep doing multiple surgery in a young lady who wants fertility. So these things, if you discuss with them and if she's okay with, following up that ovary, and when it comes back you can remove, so you can do that as well. But in a micropapillary variant, the risk is a little more higher. So that also has to be explained.
Thank you.
Okay, so she's explained the risk of recurrence and how to follow up if we've done just a cystectomy. In those who require ART, we can go ahead with an ovarian stimulation for egg retrieval. And should we give, Jnanashankar sir, should we give some time period to go ahead and do the ART procedure next? Or can we go ahead?
We must go ahead. Why do you want to wait?
Yeah, we can just go ahead, and there's no data to advise any delay between the borderline treatment and ART. Yeah, I think now we'll switch back to Kartika for a lighter discussion of what we do day in and day out of how we do a cystectomy. Kartika, are you there? Do we have
Can
time?
we'll have that as the last case, Divya? Kartika's one case.
Last case.
Yeah, sure.
We'll wind up with that.
Yeah, we'll have one case.
Since we have discussed, am I audible?
Yes.
We discussed the decision points a lot. What we will be discussing now will be about a case of a huge ovarian, huge cyst occupying the entire abdominal cavity, as you can see. And on MRI, it was given as a huge cyst with no septations or solid areas and probably of ovarian origin. The tumor markers were normal. I'm going to skip the question of laparoscopy versus laparotomy. Here we are going to discuss about the laparoscopy. First, I would like to ask Jnanashankar sir about what entry point would you like and which method would you prefer, sir?
Okay, here certainly any closed method, she has got a risk of a direct entry into the cyst itself. So I would try the preferably go with the Hassan's technique, open technique, maybe a little bit even larger, so that we have time to go assess the cyst outside, cyst to all rest of the peritoneum without creating initial spin. So Hassan should have been my first preferred, but here you are showing Visiport, I think.
Yes, sir. So this surgical video is of Divya ma'am, and she said this is Paul sir's favorite as well. So that is why I had put this video. And is there any other point anybody else would prefer? Tarun sir?
I think pretty much maybe entry to a Palmer's, but I think like you said, since we are dealing with a clear cyst, sometimes I would aim to enter into the cyst so that I can just drain the entire thing out if I'm quite definite that it is not a malignant cyst from the findings of my scan or MRI. So either Palmer's or even entering into the cyst, like I said, is not something that I would exclude sometimes.
Would anybody prefer an epigastric port or say optic trocar? Damodar sir, do you do it that way?
No, I generally I use a Palmer's. I put the berries at the Palmer's, and then I go in. I put a 3 mm trocar at the Palmer's and put the 2.9 histoscope in there and have a look. And and because it's benign, even if you've entered the cyst, it's all right.
So in this case, what we found out was it was a para-ovarian cyst. But if it was an ovarian cyst, I would like you to just enumerate the way you will do, whether you will be excising the excess cyst wall and leaving only the hilar part of the cortex, or what technique would you be generally using for a cystectomy of a huge size? Jnanashankar.
Yeah. Actually, we had discussed this in the first case, I think. So at the places where the cyst wall is too thin, the ovarian cortex is too thin, no point trying to preserve it. I feel anyway it is going to be non-functional. So at extremely thinned out ovarian cortex, I really actually prefer excising rather than trying to preserve it. But when it comes near the hilum, that is where the real challenge is. So try to minimize giving cautery there and try to use other methods like compression or if it's very minor wounds, just observation. If it is a spurter, then we might use a spot coagulation. So that would be my mode.
Yeah.
I
So,
think
yes, Tarun, so you were about to tell
no,
me.
I think pretty much the same thing. Only thing that I would add is we don't start your dissection from the thinnest portion, because thinnest portion to get the plane is going to be difficult. Sometimes from a slightly thicker portion you start, you get that plane, and then walk on it going back and forth. But I think I agree with what Shankar said. Don't try wasting time peeling out from areas where the cyst is very, very thin. Just excise those portions and save enough ovarian cortex to, for her to have fertility. That's her plan.
So, sir, especially in cases of huge cyst, what we are left faced with after the cystectomy is a large portion of ovarian cortex left back. Does any of you prefer reconstruction? And in case of hemostasis, again, is it going to be a hemostatic suture or a bipolar that you would prefer, considering she's a young girl?
Yeah, if it's huge and if you're not able to sort of collapse it and put it back into the POD, then it's I think it's wise to take a suture than anything else because it brings everything back together. And you can also try, sutures from the inner lining of the cyst and then bringing it back together rather than taking it in and out through and through. So the chances of adhesion formation are also low in the future. So the sutures are not exposed basically to the peritoneum.
Jnanashankar sir, do you have any other, do you prefer suturing for reconstruction
Yeah,
purpose?
see when the like such large cyst if you are removed, you will see the remnant ovarian cortex is too splayed out, too wide. So it is better that we actually bring them together rather than leaving them in such a splayed manner. So I would not take a complete closure of the opening. Rather prefer taking maybe an interrupted suture or use a V-lock and then take sutures at distance so that you try to reconstruct the ovary. It may not be near perfect, but at least an approximate reconstruction will be better rather than leaving a splayed open ovary.
So especially in this case, where it is a paraovarian cyst, how do we identify the tube and avoid damaging the tube? Because most of the time the tube is going to be splayed over the cyst.
Yeah, certainly.
Do you have
any paraovarian cyst, naturally you'll find that the tube is actually stretched and elongated. Initial days of practice, I used to get worried and then try to remove the tube. But nowadays, we find that all gynecologic structures have got the ability to expand and then regain its shape back. So even if it is stretched this long, you see that in repeat laparoscopies, the tube actually has regained its length and has actually shortened. So we always try to preserve the tube and also the vessels which go to the tube. In paraovarian cysts, the difficulty I encounter is when it is coming very close to the ovary. You'll find that it is attached firmly to one pole of the ovary, typically the lateral pole of ovary, where you might have to sacrifice maybe a couple of millimeters of the ovary to actually give a complete excision of the paraovarian cyst. But the tubes almost always will be able to preserve. Try to preserve the tube as well as its vascular.
Yeah. One thing which I do is wherever we put the incision afterwards, when we proceed, we try to, look back on the tube every now and then, make sure that we are parallel to the tube so that we are always peeling the tube away from the area and rather than going directly into the tube, and use the bipolar cautery also to a minimum to avoid that devascularization of the tube also.
So finally, we'll finish up with this question, specimen retrieval. Since I know Damodaran sir prefers colpotomy, I think I'll ask him a bit later. Does any of you other people prefer bag? If so, which port and which bag do you prefer, sir? I think I'll go with Tarun, sir.
I think I'm also a big colpotomy person. As long as we've taken consent for that, I would do colpotomy. But if not colpotomy, but wherever we are removing it nowadays, it's always in the bag. I don't think whatever we remove now, it's ideally in a bag when we're removing it. I use the lateral port, the point just above the antesuppiliac spine, and enlarge it, and I take it out through that. Bag preference honestly depends on the patient and my comfort. You have the expensive automatically open bags, which it's easier just pop in. It opens up automatically, easy to put the thing and take it out. And then you can go down all the way to budget level if you want. Take your Euro bag, cut it open, and use that. So honestly, depends on your preference, but definitely in a bag.
If you're removing it by colpotomy, would you bag it and then take it out, or will you
Ideally,
just?
yes, I do. I do bag it nowadays. Whatever I'm taking, I try to put in a bag and remove it. But if you'd asked me a year ago, then no. So I had to just remove it from below.
You had burnt your finger somewhere, but
Yeah, so one time is enough.
okay. So what I would say is the fear of having a bag is the spillage part. But that has already occurred because during this dissection only we have done enough spillage and rupture. Or if I'm going to do by colpotomy, many times I would just take it out without going for bag.
What about seeding, sir? Endometriosis and.
Oh, okay. Like you see, in this case, they had actually taken it through the tenement port.
Yeah.
Like the cyst they took intact through the tenement port without having any contact of the system wall to the abdominal wall. That I think
that is fair. Yes, sir. Yes, sir.
So for nowadays for some dermoid cysts, when I usually do the lateral port, because if there is a spill also, the spill is contained inside the pelvis and I can wash it faster and easier. Rather than if I go in the umbilical port and if it spills a little bit from the bag, then washing the upper abdomen is the entire.
But just that then you're
bit tedious.
enlarging one more port. That's the only.
Okay, so every dermoid I will put in a bag because I don't want the spill. Actually, chemical peritonitis as such, I think is more theoretical. I think I'm not sure any of us have encountered it.
No, I've never.
But actually, giving wash after a dermoid spill is actually a long process, and you'll find it is tough to take out all the sebaceous material and fat. So we prefer having the spillage within the bag. So all dermoids, I generally try to put in a bag and then try to.
Sometimes you put it in a bag, and while taking it out of the port, that port, there's a hole in it because of you putting your instrument there, or it can give way at some point, and you can have a spill sometimes there also.
And then sometimes you'll find that the solid component of the dermoid is very big. Sometimes it's very hard because you can have even a bony cartilaginous component.
Yes,
you'll find that it just doesn't come out. You might have to extend the port. So actually, that is where, like Damodar, we find the taking it out through the POD actually is advantageous.
Yeah, POD is a beautiful thing. I think everybody should be absolutely using that for everything. So.
Yeah, actually, I think so. I think it's very important to use, especially for the dermoid. If you can use the colpotomy, you are actually moving all the content to the POD. Raise the head end so all your fluid comes there in case there is an accidental spill. What we call chemical peritonitis is usually because of small hair which comes out. The hair can be very disturbing and they can cause multiple sinuses. I've seen a patient with about 15 sinuses which had to heal. That is terrible. So the hair, if it falls out, it's a problem. I don't know, the other peritonitis may not be that much, but still you can have a lot of fluid peritonitis. So I think for dermoids, it will be ideal if everybody learns colpotomies. Even for a parovarian cyst, you can take it out through the side, it doesn't matter. But for colpotomy, for a dermoid, I think is very, very ideal if you can. Perhaps in a pregnancy, maybe it may be difficult, but in all other dermoids, bag it and take it out through the vaginal colpotomy.
So, how do you do the colpotomy? Do you use a cup or do you just use a gauze?
I place a CC ball from below. You can either place that or you can place a sponge on a stick and just make that area prominent between the two uterosacrals, and then you just go slightly below that and then you make an incision. And ideally a transverse incision. And if you want, you can make a cruciate also if you want to extend it a little more. And even if it's a dermoid, I think you would bag it and then take it out rather than just trying to take it out directly from below. So if that, I would still use a bag to take it out.
Does Dr. Paul have an opinion if he is still around? I think he's not there.
Yeah.
Okay.
So finally, I would like to ask one question to Dr. Kavita ma'am. How would she have proceeded with the very huge cyst? Because generally, oncologists sometimes, like if there are even one or two septations, they prefer to go for an open surgery. And I know Madam discussed in detail about it, but for a very large cyst with maybe one or two septations alone with no solid areas, and how do we proceed for a very young girl, Madam?
I'm very sorry. It's because again, I will be like I probably am the odd man out here. So when you have this large kind of cyst, the first thing that comes to our mind is a mucinous tumor. Of course, it can be a para-ovarian. You could start off with a DLAP and see where exactly it's arising from. If it is definitely a para-ovarian cyst, you probably can proceed in the way that you've gone. But if it is from the ovary, now when you have this large cyst, just septations alone, it can still be a mucinous tumor. And these mucinous tumors, we don't like to spill. Now, there are different types of mucinous tumors. Occasionally, you can have mucinous tumors. They can be benign, just plain benign mucinous tumors, which can arise out of a dermoid. Now, I've seen very large, huge mucinous tumors, and after removing that entire mucinous tumors, cutting it open, you'll see there is one small area of, that hair and that Rokitansky nodule, which is entirely missed by your imaging, ultrasound, MRI, everything. So the mucinous tumors which arise on top of a dermoid, it can be benign or borderline, it needn't be malignant, but the behavior is different from a regular mucinous tumors which arise on an ovary. Now they behave like your appendicular neoplasms. Even their IHC pattern, everything is like an appendicular neoplasm. So they have a very high risk of pseudomyxoma. So when you spill those benign mucinous tumors, I'm telling benign, so it need not be borderline or malignant. So if you spill those, now there is a chance that these patients will develop pseudomyxoma, just like your ruptured appendicular low-grade mucinous appendicular neoplasms. So that risk is always there, and you will never know. So this is not a very common scenario. It is very rare. But since we've seen it now, it like Tarun said, once you see it, then it kind of engraves in your mind. So very large tumors, there is always a possibility of mucinous tumor. Now you have this imaging, you should learn to kind of read the imaging. Now when you have an imaging and you have a small papillary projection, this papillae, one or two papillae, then you know it's definitely a serous tumor. Now when you don't have papillae and only septation, it can be a serous or a mucinous or a seromucinous tumor. There is a possibility, mucinous possibility is much higher in very large tumors. And when you have these locules with different densities, when you do a CT or MRI, you'll know there are different shades of gray present. So if it is like that, it is most probably a mucinous tumor. But what exact variety of mucinous tumor you will get only with final histopathology. By and large, these mucinous tumors do very well. Now, even these benign mucinous tumors, which are not part of your dermoid component, if you spill, nothing will happen. The only difference between a serous and a mucinous tumor is you will not do a cystectomy. There is a chance of recurrence of a mucinous tumors, and if it recurs, it will recur in a higher stage. Like for example, if it's a benign, it will recur as borderline, and then it will recur as a mucinous carcinoma. So in a mucinous tumor, because they are unilateral, you gently try and do adnexectomy. That ovary has to be removed. We try and do, when you have a bilateral mucinous tumor, you always think in terms of a metastatic. You must rule out metastasis from colon or other sites when you have a bilateral mucinous tumor and mucinous tumors with these implants outside. Now we talked about the serous tumor with implants. So that is possible, but mucinous tumors with extra ovarian implants is not present. So when you have mucinous tumors and jelly outside the abdomen, it is most probably a metastatic from outside elsewhere. So that is how I manage these kind of large.
I kept the question last for you, ma'am, but I would like to ask you just one more question. Convincing a young patient to go for a large midline scar is very difficult. Can we put one small scar and then drain it and then take it out and do a cystectomy? I'm sure.
Generally, see, that is what I'm telling you. The serous tumors, sometimes, very occasionally, this controlled kind of rupture we've done, like I told you, right? So if your imaging is very convincingly, borderline or a benign appearing serous tumors, we do that. We've done it. The patient is so bent upon this, but mucinous absolutely able, because the pseudomyxoma, once you see, these patients, they keep coming back. They'll need multiple surgeries. And you can't do anything. They're not responsive to chemo also. So somehow mucinous, if I have a suspicion of mucinous tumor, I convince the patient. patient. And even if she goes off to somewhere else, it's fine because I don't want to do. That's the only thing.
Okay.
Thank you. I think I'll hand over to Divya, ma'am.
Yeah. Rekha
One
ma'am?
small addition. Hello.
Yeah.
Sir, you're audible.
So what I do in our center, select cases, okay, not generalized, not for everybody to apply. So we have facility for frozen section in our place. I think Dr. Kavita made it very clear for all of us. So at our center, we have frozen section. So we generally tend to use frozen section for patients where it is indeterminate by imaging. And at FS, by waiting for 20-30 minutes, you have a report. If it comes as obvious malignancy, then we go ahead and do primary laparoscopic staging. That is lymphadenectomy, omentectomy, and selective peritoneal biopsies. And we also tell all these patients that frozen section is not like we can have pitfalls. So if the final biopsy report comes after 2 weeks, has got invasive component, that she might require a restaging laparoscopic procedure. So primary laparoscopic staging, we have to take with proper consenting from the patient, attenders, everybody very clear that that you are doing this for these select benefits. But very clear from my viewpoint, no, so that I don't want to be put into question. So I will make sure that there is no spillage. Okay, so as long as the size is around 5, 6, 7 centimeters, okay. More than that, I think in spite of all your efforts, it will spill. Then you could be caught into question. So primary surgical staging for CA ovary is feasible, but only in select centers after proper consent.
Okay. I think we had a very extensive discussion of starting off from benign to borderline to malignant and how to go ahead. It gives us a lot of scope on how to, manage the patient better. And we always have surgical gynae oncologists who can always help us with the decision making and as well as proceed with the surgery. Rekha ma'am,
Yeah,
can
so
we conclude?
thank you very much. And I think we have overshot that time also.
Yes,
I
ma'am.
think a lot of wives will be angry and husbands too. So it's 8:30. Please have your dinner. I think I must thank Divya, Kartika, and all the other panelists who came in and contributed in such a big way. Jnana Shankar, Dr. Paul also, I think, probably has left. So please have a good night.
Yeah.
And yeah,
Thank you, ma'am.
meet you at the next. Please come for our next meeting, which I think will be, when is it, Damodar?
Ma'am, I'll come up with a date soon, ma'am.
Okay.
We'll have to have a meeting also, and then we'll
Yeah.
decide on the dates.
So thank you to all the participants who joined in, the delegates. Thank you very much.
Thank you,
Thank you.
ma'am. Thank you for the opportunity. Thank you to Chitrakala from Shield also, who gave us this webinar platform, and it went on very smoothly. Thank you.
Very
Thank you
nicely
to
done,
Shield.
Divya, and lovely
Yeah.
panel. Very
Thank
nice
Thank
you.
discussions. Thank you. Thank you so much.
Thank you.